So much, and a huge thank you to Dr. Tran and Dr. Bittman for agreeing to be our panelists today. Myself and Dr. Tran do not have any disclosures. Dr. Bittman receives speaker fees, travel bursary, and memberships on advisory boards, as you can see on the slide here. So, as well aware to this audience, hypertension is a really global public health issue. But today we've chosen to speak about resistant hypertension, which affects about 10% of people with hypertension. And resistant hypertension means that blood pressure is above target or uncontrolled despite receiving 3 or more antihypertensive medications at optimal doses. And in most definitions, people include that the patient should be on a diuretic as one of those 3 medications. The other definition could be controlled blood pressure to treatment target despite the use of 4 antihypertensive medications or more. And resistant hypertension is important because it has a poor prognosis. These patients are at increased risk of cardiovascular events, of heart failure, of stroke, kidney disease, as well as premature death. So we've designed this webinar to be quite case-based. We'll start with the first case. This is a 60-year-old man who's had hypertension since age 35. He's on 3 medications, including a diuretic, as you can see here, amlodipine 10, hydrochlorothiazide 25 milligrams daily, and telmisartan 80. On physical examination, his clinic blood pressure is 165/72, and he does have an elevated BMI of 32. The rest of the exam is unremarkable. And his baseline labs, as you can see here, is potassium, sodium, bicarbonate, creatinine of 80, and an ACR of 10. So I'll start by asking, how would you approach this patient with an elevated clinic blood pressure despite being on 3 antihypertensive medications?
So my first approach in trying to confirm the diagnosis of hypertension is that most cases of uncontrolled blood pressure in the clinic doesn't really equate to just being resistant. There are several things that we need to take into consideration. And one thing is we need to rule out white coat hypertension in these patients. We also know that improper blood pressure measurement in the clinic can also account for about a third of these patients being considered resistant when they're truly not. And it's really important to use out of office blood pressure measurements, either through home readings or a 24-hour blood pressure monitor to kind of rule out the white coat effect. Because again, that can affect about 1/3 of patients. So I just wanted to kind of clarify the differences between white coat hypertension and white coat effect. So generally, people who have not been told that they have hypertension and not taking medications, they can have white coat hypertension if their blood pressure is higher in the office, but lower in the clinic. I mean, lower at home. And then similarly, patients who are already taking blood pressure medications, they can have a white coat effect, whereas their office blood pressures are much higher, but their home readings are lower. So it's really important for these individuals to have either out of office blood pressure monitoring, either 24 hours or home blood pressure series, because their blood pressures can increase over time. This is just a study from Myers from Toronto, and it really just highlights the fact that blood pressure measured in the office has a big discrepancy. And part of Hypertension Canada, it's to use automated office blood pressure measurements. You can see in this slide, the first blood pressure measured in about 50 patients averaged to be 162. And after 5 measurements with the automated office blood pressure monitor, at this case was the BP True, their blood pressure evened out to be 142. So as you can tell, there's about a 20 millimeter mercury drop in blood pressure, which has a big effect in classifying those that have hypertension. Again, this is just a 24-hour blood pressure monitor. And it really highlights that those that have white coat hypertension, their first blood pressure readings are quite elevated initially when they have this machine set up. So it's about 160/80. And then subsequently, after the 24-hour blood pressure reading, this series showed an overall mean of 116/59. And this patient was only on amlodipine 5 milligrams. So it really shows that they had a component of white coat hypertension that was affecting their office reading. And this is just a promotion for the Hypertension Canada list of blood pressure recommendations. We've recently revamped the website, and the QR code is there for your reference. And it provides information for patients and physicians on how to select the ideal blood pressure machine. We go through all the machines to make sure that they're validated because we want to ensure that we have accurate readings. And it helps streamline selecting those that are in clinic, 24-hour ABPMs, as well as home blood pressure monitors for different patient populations.
Great. So back to our patient. So this is our patient on 3 medications with an elevated clinic blood pressure of 165/72. So we did go on to do a 24-hour blood pressure monitor, which did confirm uncontrolled hypertension with a daytime mean of 153/70. So now how would you approach this patient with an elevated 24-hour blood pressure monitor despite being on 3 medications?
Great. So now that we have confirmed that this person has high blood pressure, there's sort of two main questions left in my mind. There's why do they have such difficult to treat high blood pressure, resistant hypertension, and what are we going to do about it? So I'll talk a little bit about the why. So there's some basic things that we want to think about. First is addressing medication adherence. Are they actually taking the medications? In preparing this slide, we all sort of have, all three of us discussed that we have experience with patients who stopped their medications for affordability because of side effects, and they haven't necessarily always volunteered that information up front. We also have patients who have another specialist has changed their medications without telling us, and then the patient will say, nope, I'm on exactly the same thing, nothing's changed. And when you go through it, somewhere along the line, our information became outdated. So we want to make sure that we're correct with what they're taking, that they're actually taking that. And then we want to look for other contributors, substances, alcohol, other herbals, other medications that can increase blood pressure, recreational drugs. We want to think about other health behaviors and obesity, salt intake, restaurants, things like that. And then we get to what excites me, the secondary causes. So we'll discuss those. When I'm thinking about secondary causes, I usually in my mind break them into 3 groups: endocrine causes, renal and renal vascular causes, and other. So the more common things that we're thinking about: primary hyperaldosteronism, less common but important to think about: Theo, Cushing's, thyroid, of course, common as well, and parathyroid. Renal chronic kidney disease is going to be a very common cause of high blood pressure and difficult to treat high blood pressure. Renal artery stenosis and fibromuscular dysplasia, a little less common. And then sleep apnea is something that I find is often overlooked or missed when patients get referred to me. So general workup, we can that I would do on most of my patients who come to see me. Out of office blood pressures, whether it's the 24-hour blood pressure or home blood pressures. Calcium and TSH gets done on pretty much everybody that comes to see me. And then aldosterone-renin ratio, level 3 sleep study for anybody with resistant hypertension, and then your Cushing's and Theo workup with, if it's appropriate, if there's signs and symptoms. Not everybody needs that testing done. Cushing's, I'm thinking about if they've got signs, if they've got this sort of weight gain in the appropriate pattern, if they're having bruising, muscle weakness, things like that. And one thing that I've often see done is that that patients are sent to me with a morning cortisol done. And so if we are thinking about testing for Cushing, just thinking about appropriate testing, because the morning cortisol is really more for adrenal insufficiency and isn't going to tell us that much about cortisol excess. And then pheo, if we're thinking about signs or symptoms, the very labile blood pressures, and palpitations and headaches and sweating and pallor and things like that are what we're going to be thinking about there. All
Great.
right.
So you mentioned that you would do renin and aldosterone testing in this patient. So one thing that comes up often is, can you or should you test the renin and aldosterone while the patient's taking their current medications?
Um, so
Sorry.
can you go back? Yeah, thanks. Yeah, so we definitely can do the testing. It's from a sort of a specialist perspective, it's important to consider the how the medications might be affecting the blood pressure. So the newer guidelines are going to recommend that we can do the testing on medications, and we just consider the effect on the test. So hydrochlorothiazide and telmisartan would be more likely to cause false negatives. So if we're seeing a negative, positive rather, than we're going to think that it's more likely a true positive. And where if we're seeing a negative, we might wonder if it is in fact a false negative. Importantly for him, his blood pressure is fairly uncontrolled on office and out of office readings. And so I'd be really hesitant to stop his good medications, his high dose of telmisartan, his reasonable dose of hydrochlorothiazide, and put him onto less effective medications like verapamil, doxazosin, or hydralazine in order to do the testing. So my approach here would probably be, in fact, start one of those agents because his blood pressure is uncontrolled, get the testing. If it's positive, I'm fairly confident that it's positive. If it's negative, then I'm going to have to think, once he's controlled, do I want to start sorting that out? Or am I going to be going on to a medication like spironolactone anyways?
So how common is primary aldosteronism or PA in the primary care setting?
Yeah, very common, which is why we're talking about it and why we're all here today. So, in a general population of patients with hypertension, we're going to be thinking anywhere 4 to 6%. So, about 1 in 20 people with high blood pressure are going to have primary hyperaldosteronism. It's sort of two caveats to that is that we recognize primary hyperaldosteronism is a spectrum of disease. And so not everybody is going to have some of the more severe phenotypes where they're going to meet criteria for surgery. Some patients are going to have a sort of more mild aldosterone excess. And that's where we're going to see that's why we see such variations in the reported prevalence, because it's going to depend on the cutoffs and criteria used to confirm that diagnosis. In patients with resistant hypertension, however, it can be up to 25%, so up to 1 in 4 patients with resistant hypertension will fall somewhere on that primary hyperaldosteronism spectrum. And we care because the prognosis is worse for patients with primary hyperaldosteronism relative to primary hypertension, even with the same blood pressure control. So we know that aldosterone is doing something, having some negative effect in the body. And we want to be able to, and we want to treat that directly, either with MR antagonist or adrenalectomy to improve those outcomes. So who should we test? Hypertension Canada would say anybody with resistant hypertension, anybody with unexplained hypokalemia. Notably, with resistant hypertension, you don't need to have hypokalemia. You can have normal potassium. So back to our previous patient, he had a normal potassium, and I still recommended that we went on to do the testing. Anybody with adrenal adenoma and hypertension, because they are the hypertension guidelines. The Endocrine Society would expand that to anybody with the blood pressure over 150 or 100, and anybody with hypertension and sleep apnea, as well as those with first degree relatives with PA. And notably, it's really under-tested. Only about 3% of people for whom screening would be recommended actually underwent testing, so we're missing a lot of patients that could be treated better.
Great. So our patient did have renin aldosterone testing, and the renin was 5 nanograms per liter. And we'll go over, there's many different units for renin across Canada, but this is one of them. And aldosterone was 660 picomoles per liter. So it comes up often, what is a suppressed renin, or when should we be flagged to think about PA?
Yeah, so there's a few different things that we're going to get reported. We'll get either renin concentration or renin activity, depending on the lab. And realistically, what I do is look at the normal ranges that are reported on that. And then if we see it on the lower end, not necessarily below normal, but if it's on the lower end, that's where I'm going to start thinking about it. And I don't wait for it to be outside of the normal range because we know that the medications can interfere. The medications that this person's on, for example, hydrochlorothiazide and telmisartan, can both increase the renin concentration or renin activity. That's one of the ways they cause a false negative. And so even if it's not quite at that target or below that normal range, we'll be thinking that this is probably abnormally low for this patient. And then the renal aldosterone ratio is the other tool that we use to sort of confirm that diagnosis. But then again, those normal values and cutoffs are in people off medication. So we have to think about how we're adjusting that. But for our patient, he's back in that sort of right at that cutoff for the renin that we had as a normal range while he's on hydrochlorothiazide and telmisartan. So I'm thinking that's a pretty significant value.
Agree. So this patient was referred to a hypertension specialist with the suppressed renin and aldosterone. Was not interested in surgical management, and so spironolactone was started with significant blood pressure improvement. And so the likelihood of primary aldo was thought to be high, and amlodipine was weaned off to maximum dose of spironolactone over time.
I'm just going to make one more quick point on that.
Yes.
There about where he was referred for hypertension specialist. I think that anywhere sort of around there, once you've decided that the aldorenin testing is appropriate or with the results, I think it's reasonable to have a specialist involved to help interpret those results, as well as to help have that discussion around surgery, because there is some nuance there around the benefits and risks of surgery, as well as sort of obviously interpreting those tests can be a bit difficult. So I think anywhere around there, either reaching out to the specialist to help to have a discussion or referring the patient on. So I think that's a great thing.
Great. So move on to the second case. This is a 7-year-old female with hypertension since age 52. She's just known for hypothyroidism and hypertension. Her medications are atenolol 50 milligrams daily, ramipril 10 milligrams daily, and amlodipine 5 milligrams daily. Previously, she had been tried on 10 milligrams of amlodipine, but that was reduced due to leg edema at that higher dose. She did have a workup that was negative for secondary causes of hypertension, and you can see that the hypertension was confirmed with out-of-office monitoring showing elevated blood pressures of 150 over 83. So we'll ask Dr. Tran, how would you approach this patient?
So now that we have a confirmed diagnosis of resistant hypertension and her secondary workup is negative, I think we can really focus on trying to maximize and ensure that she's on the best blood pressure medications. The way I think about it is I like to start an ACD method where the first agents I usually use are a backbone of either ACE inhibitors or angiotensin receptor blockers or ARBs. Either a calcium channel blocker or a diuretic. And I find that what works best is having some form of this combination for all patients. So if they've already been for this patient, she's already been on an ACE inhibitor and a calcium channel blocker, but she's not really been maximized on a diuretic. I would consider adding the diuretic to help improve her overall blood pressure. Obviously, with those that are elderly, beta blockers aren't usually preferred unless they have another indication, either it be like heart failure, angina, previous MI, or atrial fibrillation, because it just does not work as well in controlling blood pressure. We know that with resistant hypertension, patients tend to have a lot of extra volume and they're very salt and fluid sensitive. So that's why really trying to maximize your diuretics has a really great improvement in their blood pressure. And after I've really maximized their ACE and ARB, calcium channel blockers, and diuretic, and if they're still resistant despite that, I would consider adding spironolactone on next. And the reason why I choose spironolactone, it's based on this clinical trial called Pathway 2. Before, we actually really didn't know what agent was the best to use. And as a result, they were thinking, is it better to use spironolactone, bisoprolol, which is a beta blocker, or doxazosin, which is an alpha-1 antagonist? So they did a trial where they looked at patients that had resistant hypertension. There was about 335 patients between the ages of 18 to 79, and they really had resistant hypertension because they had both elevated office and home blood pressures. They needed to be on the backbone of blood pressure medications I was telling you about. So they had to be on their ACE or ARBs, they had to be on a calcium channel blocker, and they had to be on a diuretic. And they excluded those that were not taking their medications and those that had secondary hypertension. And their primary endpoint was looking at how these medications affected their home blood pressures. What was really interesting about the study design was that each patient acted like their own control. So patients would start off in the placebo arm for 12 weeks, and then they would move on to the beta blocker arm of bisoprolol. And then after 12 weeks, it would move on to spironolactone for 12 weeks, and then subsequently to doxazosin for 12 weeks. What was really important was that halfway through the intervention, they had to force increase their medication. So people who are on 25 milligrams of spironolactone, after 6 weeks, they all had to have that force increase of 50 milligrams. And this is really important because we know that treatment inertia, sometimes not increasing their medications, can also really prevent optimal blood pressure control. Overall, the patient demographics were about 61 years old. About a third were women. 14% had diabetes, and they were actually quite hypertensive based on their home ratings, averaging about 148 over 84. What this shows is that spironolactone had the biggest reduction in their systolic blood pressure. They reduced it about 12.8 millimeters of mercury. Then it was doxazosin and bisoprolol were fairly tied between 8.3 to 8.7. And even placebo had a small reduction in their blood pressure. What they found was that more people had better blood pressure control on the spironolactone arm compared to doxazosin and bisoprolol. And that's why we really encourage that as the next agent to put it on when someone has resistant hypertension. Overall, patients found that spironolactone was really well tolerated. They didn't usually have that adverse effect, which is usually gynecomastia, partly because the study was so short. It was only 12 weeks in duration. And there's also very few patients that had hyperkalemia. Partly the reason why is a lot of these patients had very normal renal function to begin with. So were not the type of patients that were high risk of developing hyperkalemia. But this is obviously something that we check. And oftentimes with spironolactone, the nice thing about it is that it has a linear improvement in blood pressure. So the higher the dose you use, the more blood pressure lowering you're going to see. And oftentimes the main thing that really limits how much we increase it by is side effect profile, specifically gynecomastia, as well as hyperkalemia or changes in their creatinine.
Great. So we're going to have lots of time for discussion, which is great. So just as a summary for what we talked about today, thus far is that when we're managing resistant hypertension, the first step would be to confirm the diagnosis. So we talked about ensuring good medication adherence, making sure that the clinic blood pressure readings are accurate with ideally an automated blood pressure monitor, and then having some sort of home or out of office readings with either a 24-hour or home blood pressure monitoring. And then considering at least a limited and then in some cases more extensive workup for secondary causes of hypertension in patients with resistant hypertension. As with all of our patients with hypertension, thinking about health behavior modifications, which can be quite effective for lowering blood pressure. And then when we're talking about pharmacological management, reviewing their current regimen, making sure that they're on appropriate doses of the medications, on a diuretic, and then as our add-on, thinking about an MRA antagonist like spironolactone. So I'll just stop sharing, I think, so I can see the questions. So and please feel free to continue asking questions as we go. So we have the first question would be, how would you manage a patient that develops gynecomastia while receiving spironolactone as fourth agent for resistant hypertension?
So what I usually do is I switch them to apilorone. This is a direct mineralocorticoid receptor antagonist, so generally has less side effects of gynecomastia. The problem with that is that the medication doesn't work quite as well as spironolactone, just because it doesn't have that diuretic effect. So normally what I have to do is I start them at higher doses, and I usually have to dose it twice a day. So for example, if someone was on spironolactone 25 milligrams, and that's when they developed gynecomastia, I might start the patient on apilorone at 25 milligrams twice a day. Sometimes I find this medication, depending on where you're from in Canada, it may not be covered by special authority, so it can be a little bit more costly for your patient. But I do find that sometimes we're able to get special authority and coverage for the medication if we can explain that side effect and the importance of being on it.
Two other things that I might mention about that. So I agree. I think that it's separating out the patients with primary hyperaldosteronism where we're using it, and the MRA activity is really important. So I agree. Using a pleuronone and even a amiloride in those patients if they can't afford the pleuronone, and then the patients without PA. Then the asking them to manage the cost of a pleuronone might be a little bit more difficult to justify in a amiloride, or looking at the other options would be sort of reasonable. I think one other important thing there is that the gynecomastia, if it's been around for a while, it may not improve when they stop spironolactone. And so really sort of looking for that side effect early, and not waiting for it to get worse before you're making that change, and then you're looking at surgical treatment, and that is very difficult to get covered.
Yeah, in Ontario, it's covered for patients with heart failure, but not specifically for patients with PA, which is a bit silly in my humble opinion. But sometimes you can kind of get it covered through these back routes. But I think that's, yeah, I didn't know that actually, that the gynecomastia could be irreversible if it's a long time. So that's an important point. We have a question for patients with pseudo hypertension, and so when secondary hypertension is ruled out, or do you mean resistant hypertension? Maybe is in the question. Do you ever consider clonidine if they're already on spironolactone? Yeah, sorry, in
I can
resistant
take that
hypertension.
question. Yeah,
To
I can
clarify,
take,
in resistant hypertension.
yeah. I find that oftentimes we have this other term called refractory hypertension, where patients are still uncontrolled despite being on 5 medications. What happens in these patients is that like I said before, like a lot of volume and salt and fluids can drive a lot of resistant hypertension. And once you're kind of started on diuretics and spironolactone, you've kind of taken that equation out. And if they're still quite hypertensive after that, you really are thinking maybe there's like something sympathetically driving their hypertension. And in those cases, I do find that clonidine, alpha blockers in general, either doxazosin or adding a beta blocker might be really helpful in kind of controlling their hypertension. There has been some trials looking at comparisons between clonidine and spironolactone, and it doesn't have like in office differences in blood pressures, but spironolactone did have slightly better 24-hour blood pressure control compared to clonidine. My only, I guess, like experience with clonidine is patients sometimes don't love it. They do get like a little bit drowsy on it. They have like dry mouth, so they have a lot of side effects and intolerances. But oftentimes, if you're kind of reaching like after spironolactone, I think choosing something that picks up on like the alpha system or beta blockers would be really helpful.
Yeah, I would say I've had better experience with doxazosin than clonidine, but I
Yeah.
can't quite so clonidine causes also the like reflex hypertension, right? Or withdrawal hypertension.
Hmm.
But I don't
Hmm.
think we see that as much with like a longer acting alpha blocker.
Hmm.
I don't know if you have anything to add, Doctor.
Yeah, I agree. The patients who have used it are usually, usually it's not directly for the hypertension. It's if they're really anxious and using it for some of that sort of those other symptoms, and then sort of it helps their blood pressure a little bit, as opposed to, I've got a lot of agents that I choose before clonidine just because of that drowsiness. It's shorter acting. It's um, yeah.
Hmm. And then, yeah, I would agree with the comments in the chat that potentially renal denervation in some of these patients, which I think was addressed in a previous Hypertension Canada webinar, and people on sort of the 5, 6 medications where the sympathetic system might be overactive, maybe another option in some places. Um, there's a question, will you consider prescribing, oh, I haven't pronounced this enough yet, aprocitentan, the dual endothelin receptor antagonist. I think I butchered that. When it becomes approved in Canada, it's apparently now FDA approved.
I am not sure.
Yeah,
Do
I'm not.
I haven't looked deeply into the
Yeah.
into the evidence. Certainly, I'm going to stick with my first line agents and reserve that for a later choice. I'm not sure. I don't have a good answer to that myself.
Yeah. Yeah, me neither. I don't really have that experience. And I'm not sure if it does come out in the market, like the costs associated with it, because I find that um, a lot of the current medications for hypertension, they're pretty cheap medications compared to other things. So, and I find that a lot of my patients can't afford their medications. So I would try to stick with the tried and traditional meds first. And then if needed, then we can always approach that.
There's a question, how soon would you expect gynecomastia to develop on spironolactone therapy? I'll tell you, like in my experience, it's very dose dependent. I don't know. Do you guys have similar experience?
Yeah.
Like I think it's I find that most patients, like the patients I have developed it, like have gone like maybe closer to like 100 milligrams of spironolactone.
Mm-hmm.
I haven't had, like I use spironolactone quite a bit, but I've only just had a handful of patients get it, and it tends to be at much higher doses.
Yeah, so it's
Agreed.
hard to say how soon because they've usually had that medication titrated up over time, and then when we get to a
Hmm.
certain dose, it seems to come out. I don't know what's your experience, Dr. Bittman.
Yeah, exactly. Yeah. And then also it takes time for patients to notice it and then bring it up. So it's hard to know, when did this actually start versus now it's actually significant enough to be an issue versus we were adjusting the dose. Um, so I don't, yeah. But I think can happen reasonably early once you're on a dose that's going to cause it.
Yeah,
Uh,
that's been my experience as well. Um, where do SGLT2 inhibitors and non-steroidal MRAs fit into blood pressure control?
So I will take that one because I think that it's relevant to the case that I discussed
Sure.
because that patient actually had an elevated urine ACR, which we didn't discuss. So if they hadn't had primary hyperaldosteronism, you would have had a reasonable case to add an SGLT2 inhibitor for renal protection. And if he had diabetes and that elevated urine ACR, you would have had a reasonable indication for a non-steroidal MRA. But we're looking at sort of the evidence and the cost. So still my first line agents have the best evidence for cardiovascular outcomes for hypertension specifically. And then SGLT2 inhibitor, I'm looking for another reason to add it in, heart failure or elevated urine ACR or diabetes. And then MRA, non-steroidal MRA in patients without primary hyperaldosteronism. And I'm looking for that sort of indication, recognizing how much more expensive it is than spironolactone as an agent.
Yeah, I'll add SGLT2 inhibitors and hypertension are super interesting because, we give them to patients with blood pressures of 90 with heart failure, and they seem to tolerate it. And then sometimes patients with quite uncontrolled hypertension and chronic kidney disease will have a more robust blood pressure reduction with the SGLT2 inhibitors. So it's almost like they work as stronger antihypertensives in the patients you want them to work as antihypertensives in, which is very cool. But I would not prescribe it just for hypertension without another indication because it's quite minor. It's in like the mean over most patients is only a 3-4 point blood pressure drop, I believe.
Mm-hmm.
So, but there's most patients that we're seeing, we can find another indication.
Yeah.
I would say. Do you have anything to add, Dr. Tran?
No, I completely agree with that. And just for example, if like some of my patients have diabetes and I just need to pick another agent, then I would obviously reach for SGLT2 inhibitors sooner in their trajectory just because of some additional blood pressure benefits. So yeah, like you're totally right. It's not that much, but usually 4 millimeters. But I think overall that's going to help their overall vascular health.
And I agree it's not much, but that wasn't in a population without hypertension.
Fair
And as
enough.
we
That's
identified,
true.
maybe more effective in patients with hypertension. We do see that with most of our treatments is that they work, the higher our blood pressure is, the more they seem to benefit.
Yeah, and interestingly, like in the chronic kidney disease population, as the GFR is worse, they get less glycemic benefit, but yet that blood pressure benefit still persists with the SGLT2s. Maybe just because they're more sodium sensitive, but it's interesting. Um, do you have any experience or pearls managing resistant hypertension in patients receiving oral or IV VEGF inhibitors for cancer, such as sunitinib, who may be receiving optimal blood pressure control with the usual agents of calcium channel blockers, ARBs, thiazides, and spironolactone? Either of you have, if anyone else on the call has anything to answer, please put it in the
Yeah.
Q&A. I've seen these agents like cause kidney problems, but I haven't actually encountered resistant hypertension from them. I don't know, have you?
I had one that had like hypertension, but it was fairly well managed on the traditional therapy. So I don't think there will be any differences in how I would approach their medications I would prescribe.
I don't have experience with it, so I don't have much to add.
Perfect. Can you review the PA diagnostic approach in primary care again, please? With suspected resistant hypertension on multiple meds, you'd go straight to an aldorenin ratio regardless of presence of medications. Yeah, we didn't go too much into the guidelines because there are new guidelines coming out in 2025 from the Endocrine Society. So a lot of what we would say today is going to be changing, but maybe just from a practical clinical approach, if one of you want to go through your thoughts.
My approach, and then maybe Dr. Tran can take it and highlight anything else. So yeah, so anybody with resistant hypertension or that meets the other criteria, I would go on to do the aldosterone-renin ratio testing. I would absolutely not do the testing if they are on an MRA already. So if they're on spironolactone or a eplerenone or a finerenone, I would not do the testing unless we take that off if we feel that that's important to do. But if they're on other agents, you can do the testing. The more agents they're on, the more difficult it becomes to interpret. And I find it especially difficult if they're on both agents that are likely to cause a false negative and false positive. So ACE, diuretics, and beta blockers can cause false positive. So I find that to be quite difficult then to sort out and make use of those results. So I might, in those patients, I might try to adjust the medications. And I think that once we're getting to that stage where they're resistant, they're on multiple interfering medications, that is where it is appropriate to call in some expertise and get an endocrinologist or hypertension specialist involved in the case. And that's where I even have other general internists calling me to discuss, we did this test, they're on these medications. How do I interpret those results? Or where even I'm calling our lab specialist or a colleague to sort of help sort that out to determine the next steps, because it can be quite difficult. So back to our previous patient, their blood pressure was elevated. I would not pull them off medications. I would do the test on those two agents, and then try to sort out the results, and depending on what I found and how difficult their blood pressure is to control.
Do you have anything you want to add, Dr. Tran?
And I think like it's really important when you're talking to your patients, it really depends what their preferences are. Obviously, going down that diagnosis of PA is a lot more than just the aldorenin ratio. And it really depends. There's a series of testing that's very complex to do in primary care and does really need some specialist interpretation and organization. That it can be a very nuanced discussion to have. So I always kind of upfront talk to my patients and see if they want to go ahead with all that testing, and if they would eventually want surgery. Because if they are really thinking they're 80, they have a good quality of life, they don't really want surgery, then after the positive aldorenin ratio, I would just start them on spironolactone and call it a day and just kind of leave it at that. But then if they're younger, who have intolerances, medications very hard to control, and they're really adamant about kind of wanting further investigations. And I think it's really reasonable to continue to send to other specialists to do further testing, because it ends up being quite nuanced and complex. So it really, I think at the very beginning, having that frank discussion, so it really allows you to understand how much investigations you want to do, or do you just want to start spironolactone after that positive aldorenin ratio.
Yeah, I would agree. I will say I do sometimes send a renin aldo on a patient, especially if they're on like spironolactone 12.5, because if you have a suppressed, like I've picked up a couple of
Yeah.
suppressed renins on that therapy, then they probably have PA. Like it's, I would agree. Like I have definitely many patients in my clinic who get sent with resistant hypertension. I never feel in patients on 4 or 5 medications that I'm going to start, and who are still at 160, that I'm going to start taking off these medications. And so I have patients who I think might have PA, maybe they're older, they have an adenoma, or they've had hypokemia in the past and they're not interested in surgery. And in those patients, I treat them like they have PA. Like I get them on a good dose of spironolactone. But, I can't say for sure that they have PA. The other thing I'd say is, as we've highlighted how complicated it is to do the testing when they have resistant hypertension, which is why I think the pendulum is hopefully going to start swinging to testing people earlier,
Mhm.
before they're on 3, 4 medications with resistant hypertension. And, there are many people who already advocate for that. The Endocrine Society, in those guidelines that we show, says that if you have a blood pressure above 150 over 100, regardless of how many medications you're on, you should have PA testing. And I think, I would love for that to be implemented. So, because if patients are tested early off medications, it's much cleaner to sort out. And of course, like the end organ damage hasn't occurred yet. Um, there's a question about experience and indications for Entresto.
So I have not used it for hypertension on its own, simply based on cost and coverage.
Mm.
Uh, and so I have seen patients with sort of heart failure where they've managed to get it where their blood pressure has been difficult to control, where it now has improved. Um, but but I haven't accessed it for patients because of the cost and coverage, and it's not. And we have other agents with good evidence, so I haven't used it in that.
I would echo that. Unless they've had another indication for heart failure, I rarely would start that as a hypertensive agent.
Can you speak to the use of finerenone versus spironolactone in PA management?
So I think most of the evidence right now for PA management is with spironolactone. And it's much more affordable than finerenone. So I would probably stick with spironolactone. I guess an indication, I haven't personally used a lot of finerenone in my practice, but if they're having issues with, there are some studies to show that maybe there's less hyperkalemia with finerenone. So that might be something to think about if someone has PA and is having a harder time to control potassium with spironolactone. But I would probably in those cases see if they're on a diuretic and try to optimize it. But I'm not sure if anyone else has some opinions.
Yeah, I would say, I mean, most patients with PA don't get into trouble with hyperkalemia unless they have chronic
Yeah.
kidney disease, which of course, like I have a handful of patients like that, where it's an interesting thought. But I mean, I don't know of any studies looking at outcomes with PA with finerenone. So I don't think I'd be comfortable starting it over spironolactone or eplerenone. If it's the the gynecomastia, the other sex hormone side effects from spironolactone, I'd probably be more comfortable with eplerenone. Um, but I don't know that the data is out yet. And I think more exciting in PA is going to be like the aldosynthase inhibitors being studied in PA, hopefully in the future might be a bit stronger, kind of aldo blockade. But I'm not sure that finerenone is going to be the game changer in PA, but maybe I'll be wrong.
I think I echo that, and the and that last point about the strength. Like I think of finerenone as a less strong MRA agent, and often with PA, you're needing high doses of spironolactone already, and it's been studied, and we have evidence, and we have clinical experience using those high doses. Where finerenone, you're pretty limited on the dose, and so I don't know that you're going to get what you need with a low dose of finerenone versus spironolactone. So I would in PA, I would specifically not. I would not choose it. And my patients with PA who meet criteria for finerenone, I'm actually still using spironolactone. They have diabetes, they have elevated urine ACR. I'm still using spironolactone, assuming that we might get some of the same renal benefits and cardiac benefits with the spironolactone, though the evidence doesn't say that. I'm hopeful that we're getting some of that same benefit, but actually blocking the
I would agree completely. I mean, many of us were using spironolactone for patients with diabetic kidney disease with residual albuminuria before the finerenone trials came out, and it's not that it was shown not to be useful. There was just no RCT that was done like the one that was done with
Mhm.
finerenone. So it was sort of like an absence of data, of good data. There was data for some albuminuria reduction, but not the same kind of hard kidney outcomes that we have with finerenone. And I think that's a very good point you bring up about the strength of the MR blockade, because it's something we didn't touch on today, but we know that if you diagnose a patient with PA, just sticking them on spironolactone 12 and a half, even if blood pressure is controlled, is probably not good enough, especially if they're on many other antihypertensives. And like we have data now showing that, some of the thinking is that surgical management might be better because it's more effective, and maybe some of the medical management is just ineffective dosing or not enough MR blockade from likely low doses of spironolactone. Um,
And just to echo that point, what I usually do is after I get good blood pressure control with patients on spironolactone, I will check a renin and see if it is desuppressed. So if your renin is, we would expect to be very low in PA, but if that goes up, that might suggest that we have like fully blocked all the MR receptors.
Great point. I'm going to continue with a PA question. In your experience, have you seen patients who have had unilateral PA that are surgically managed, and are they able to stop antihypertensive medications?
I have had some patients been able to stop all medications, but I think there's a lot of things to consider. Obviously, we know that those that have had like a longer duration of hypertension, if people are on a lot more medications, if they're more, if they are males, they tend not to have such a complete response to surgery. So I think it's still worth trying. But I've had like a mixed bag of patients who still require some antihypertensive afterwards.
Yeah, I would agree. It's very dependent on the duration of hypertension, other end organ damage.
There are a couple of scoring tools to help determine who you think is going to resolve their hypertension. And I always think like, do I expect this person to have hypertension anyways, right? They're older, they're man, they're have high blood pressure longer, so they've already had the end organ the vascular damage, those types of things. And the goal of primary hyperaldosteronism in my surgery rather for PA is not to cure the hypertension, it's to cure the PA. And we know that that has the benefit, or we think that that has the benefit by reducing the aldosterone level, whether they're still on medications. And I agree, like it definitely seems to have reduced number of medications. But is that any different than if I had targeted and addressed their spironolactone and they were only on spironolactone? Yeah, I think that, some patients you would have had that response. Anyways, even with some patients, when you put them on spironolactone, I've stopped all their other antihypertensives.
And I say the literature tells us about, I think it's 37-40% will be cured, and about 80% will have blood pressure improvement or come off blood pressure meds completely. And I'll just put a little plug that in, women of childbearing age, if they can get a surgical cure before an upcoming pregnancy, that's likely to be very beneficial for them. So that's a population that I would be more aggressive of in looking for a surgical PA. Switching gears, there's a question, is there any value in trying to change a patient's medications to longer acting versions, for example, hydrochlorothiazide to chlorthalidone or valsartan to telmisartan?
So we discussed this a little bit in preparing the slides, and the hydrochlorothiazide to chlorthalidone question is we have some evidence to guide that in some patients now. There was the Veteran Affairs study that showed that chlorthalidone on average was not superior to hydrochlorothiazide in terms of blood pressure control or cardiovascular outcomes. However, there has been a sub-study, and I forget what population that was in at the moment, that showed that there are some patients who do benefit from that. And so in my patient, so back to that previous case, and that patient was resistant hypertension who was on hydrochlorothiazide, yes, I would consider switching to chlorthalidone or indapamide. Now, at the moment, we can't get chlorthalidone. It's back ordered everywhere and at all doses, so that makes it a little bit more difficult again. But I am making that switch for some patients with with resistant hypertension. And then I had a patient ask me the other day about the skin cancer risk, and it does maybe seem a little bit lower with chlorthalidone versus hydrochlorothiazide. So that might be another reason to be thinking about that switch. Not sure what you guys do.
Yeah, I mean, I try to put them on single pill combos, long acting agents, that type of thing. Do I expect it's going to like bring their blood pressure from 160 to 130? No, but it seems like a reasonable thing to do.
Yeah. Yeah, I think I usually use it if I'm just like kind of fine tuning their blood pressure. They're pretty close to their target, but maybe we just need to try this first before putting them on another agent. I'll use that. And I find that the single pill combinations and longer acting may really help with like some of the medication non-adherence. So I'll usually try to see if I can like make small modifications first.
The single pill combinations, most of them are with hydrochlorothiazide rather than
Mhm.
chlorthalidone. So that's a place where I will, and based on coverage in BC, that is a place where I'll often stick with hydrochlorothiazide if I really want one of those combos.
Um, Perfect. Just a couple comments from one of our expert endocrinology colleagues, Dr. Preptani. I don't know if people can see the Q&A, probably not, right? So just a couple comments was that the gynecomastia is dose dependent and irreversible due to fibrosis if it's long-standing. And just reiterating that even on MRI therapy, we can do testing because if the renin is low and the aldo is high, the pretest for PA is very high. I like this question. This is something I think about a lot. Any comment on the use of GLP-1 agonists for weight loss to manage hypertension? Maybe Dr. Bittman, if you want to take that. I know you have an interest in weight management.
So it's I think a very interesting question. And when you look at the studies with GLP-1 inhibitors, we think about the weight loss driving hypertension, but actually the blood pressure starts dropping before in concert with the weight loss and maximizes actually before the weight loss maximizes. So I think there's some effect beyond that, whether it's simply the dietary change or some other effect of the GLP-1. There's not a clear answer to that at the moment. So if the person has an indication for GLP-1, I will start that as I'm managing the hypertension. It's not a hypertension agent. People have variable response to it. It doesn't have the cardiovascular outcomes in patients with hypertension. It does in diabetes and established cardiovascular disease for semaglutide. So I will use that in concert while I'm managing their blood pressure. If their blood pressure is close to target, then and I'm planning to start a GLP-1, I will often say, well, let's do the GLP-1 now, come back to me in a month or two, and we'll see if your blood pressure is improving. If it's far off target, then I'm starting the agent with saying, well, if the blood pressure drops, we can always pull off your agents.
Have you had a lot of experience taking off agents on people with weight loss from?
Absolutely.
Yeah.
So we know with GLP-1, there's really variable response. And the people who only get the sort of 5, 6, 7% body weight loss with GLP-1, less sort of promise on the blood pressure side. And the people who are sort of more significant responders, the 15, 20, 25%, I'm certainly stopping it. Bariatric surgery, even more so, I'm stopping it. So it's something that I think that we should be thinking about for our patients with hypertension, is managing the obesity, whether it's through GLP-1, surgery, whatever the mechanism that we're treating it is, but not necessarily relying on that because we know those treatments don't work as quickly as our hypertension treatments. So still managing the blood pressure if it's indicated.
All right. There's a lot we didn't get to, unfortunately. There's some really good questions about when to think about renal artery stenosis and how to investigate for that, which we need another hour webinar at least on that one, I think. And on sleep apnea, and I'm sure we'd all be happy to take emails if anything comes up as well. But it's 12:59, so I wasn't going to endeavor one more question, if that's okay. But thank you so much, everybody, for the really great questions.